Good evening, everyone. Pleased to be here today. It's our day 2 of our webinar series, the second edition from our stable Occupational Therapy HubSpot team. And this is our second webinar. We are excited to have you here today. Yesterday was a wonderful day. I learned a lot. I brushed up my knowledge yesterday. It was such a beautiful time, having our speaker, Mr. Ola, remind us a lot of things, put some of our understanding into better perspective, with evidence-based explanations that he gave. So yesterday was such an insightful, formative time for me. And I believe for every one of us too. So we are here today, the day 2 of our program. And we have another speaker for today. We have, I'll get to that. But before that, you may want to come up in the chat and say good evening to somebody, or you leave in the chat, good evening, everyone. Welcome to day 2. I'd like to see our chat, start bubbling up. So if you wouldn't mind, please go into the chat and leave a message, a welcoming message. Say what you would, just leave a thought in the chat quickly. Can we do that for 1 or 2 minutes whilst we wait for others to join us? Thank you. Thank you, thank you, thank you. I'm seeing the messages dropping. Thank you, everyone. Thank you so much. Let's keep bringing it in. Drop a message, drop a thought about yesterday, about the webinar. Drop a thought, in the chat for all of us to see. We really want to know your thought. We want you to let us into your thoughts, knowing that we are giving you what you desire, what you expect of us. And we trust that we will be, so that we will be able to do much more, because that's what we want to do. We want to be able to do much more and give you much more. So thank you for dropping your thoughts in the chat, and as you continue to do that. All right, so for day 2 today, we have Mr. Abiodun Yusuph Odeyoyin, who is our speaker for today. He is a lecturer at University of Rwanda, Department of Occupational Therapy, and he is an occupational therapist. He has a YouTube channel where he uploads practical sessions, informative sessions for therapists to see, professionals to watch and learn. It's called Oya. That's Odeyoyin Yusuph Abiodun YouTube channel. It's called Oya. We know it as Oya. All right, so you can always search him up on YouTube, and you will see all of this informative and this educative videos he uploads on the YouTube. And also the rest of the team. I will be introducing the rest of the team in the person of Mr. Emmanuel Olukoju, who we call Timbas. He's on the team, and he's on this group today with the rest of the team. So, same also, we have Mr. Kayode Karim, Mr. Kayode Karim Deji, who is, we call him Karim Baba. For those of us who have been with him for a couple of years, over 10 years, we call him Karim Baba, and he behaves like the Baba that they call him anyway. He is also a lecturer at University of Rwanda, and he is here today on the team. As a member of the team, we have Mr. Solomon Olatunji, who was our speaker yesterday, fantastic young man, a fantastic friend, and we have Mr. Dokpamu Kehinde, also a member of the Occupational Therapy HubSpot. And on behalf of the rest of the team, being the moderator today, I welcome you all, and I hope you have a nice time. I hope you have a beautiful time. I hope it's worth your time and the sacrifice you have made for today. Before I hand over to the speaker for today, I'd like to quickly brush through couple of instructions and guidelines. Please, whilst the meeting, the training is on, kindly keep yourself on mute, so that we do not get interrupted and the flow of learning isn't distorted. Thank you so much. Also, for those of us who joined the WhatsApp group, which was our way of registering, for those of us who joined, thank you, Miss Latifat Adebola. Yes, it's nice to be here today too. For those of us who joined the WhatsApp group, you would have received a link to a form would want you to fill out, and as you want your name on the certificate, that is the way you should put it on the form. When the way your name comes on the form is the way it's going to come on your certificate. So for those who are on the WhatsApp group, you will have your certificate. And if you're not on the WhatsApp group, but you would love to join the WhatsApp group so that you can have a certificate, an e-certificate, you can send a message in the chat to any of the team members or even to myself. I am Damlola B. My name here is Damlola B. Banwo, moderator. You see that, leave a message for us. We will get you to the group so that you can have the form filled, and then you get an e-certificate for this training. Thank you all for coming. Whilst we're waiting for others who haven't dropped a message, a greeting in the chat, I hand over to Mr. Speaker today. And also, a quick one before Mr. Speaker takes up today, we have two members of the panelists. We have two panelists today, and I will be introducing them shortly before they come on for the question and answer session. Have a wonderful time. I hope you get to learn as much as you would have expected to. I am looking out to learn as much as I can today. Good evening, everyone. Over to you, Mr. Speaker. Thank you.
Okay, good evening, everyone. Am I audible enough?
Yes, sir.
Yes, we can hear you, Mr. Odeyoyin.
Okay, so thank you so much for that wonderful introduction. And as the moderator has said, I remain Odeyoyin Yusuph Abiodun, and I hope this particular session will be insightful and we are all going to learn something at the end of the day. So please let's mute all the microphones. Mr. Moderator, if possible, you can just help us with that.
Yes, I'm going to mute everyone now, and you can unmute yourself, sir.
All right.
Mr. Odeyoyin, you need to unmute yourself.
Okay. So, as it has been reflected on the flyers, today we are going to be discussing about block and random practice techniques in occupational therapy intervention sessions. But before I go in details into that, I would like to give us a quick recap of what the concept behind block and random practice is all about. And after that, we'll have an intensive illustration about how to implement the concept of block and random practice in our intervention practice. The outline of our discussion for today is going to flow in this particular order. So I want us to first discuss about what is the concept behind motor learning and the motor control techniques and the practice level, and much emphasis will be laid on the concept of engram or memory trace formation, which serve as the basis of neuroplasticity in order for us to engage a patient whenever the need arises. And on the last note, we'll have a short demonstration video, which will take approximately 5 to 6 minutes on all the techniques that I'm going to present. And I'll give you a quick, a better understanding of how to document intervention related to any of the motor learning concept. Now, at the end of this, I believe that the participant should be able to understand what amount of timing is required to engage a certain patient before expecting any functional outcome. And also, there is a concept around practice distribution, the variation in terms of what we practice, and what block and random practice is all about, and how to implement them in our regular sessions. So this will be the intended learning outcome of our discussion for today. Now, I don't want to take much time. I believe we have more professionals on board than the parents, so to say. So the concept of motor control, which is one of the reasons why we are here, block and random practice does not just exist. It's a concept that lands on motor learning theory, and motor learning theory, it's also from the perspective of motor control. So whatever activities that we engage our patient as a therapist, there is always a movement involved in all what we do. If you want your patient to drink water, there is certain component of movement that required holding a glass cup of water and then getting it into the mouth. So if there is any alteration in terms of the mechanism of that motor component, there is always a need for us to retrain or to train the patient in order to be able to perform that concept. So as an occupational therapist, there is need for us to understand motor control as a theory on its own before even talking about what are the practice implementation techniques that we could use in order to train the patient. The first thing I want you to understand is that all our therapy sessions are directed towards a certain goal in every patient, and the goal will focus on one functional end. Another point is that our intervention strategies are also designed in order to improve postures, which are very much essential to patient participation. So knowing this tells us that the concept of motor control, it's critical to OT practice, and when a therapist understands the concept behind motor control theories, the better they do during motor learning practice. Moving forward, in order for us to understand the concept of engaging a patient with motor control theory, there are three essential elements that I want you to take into consideration. The first point is the individual, which serves as the patient which you may intend to work with. The second component is the task that you as a therapist want to present to the patient. And the third component is the environment which will accommodate you, the patient, as well as the task. If the environment is not enabling enough, definitely you might not achieve a better outcome in terms of the patient deficit. And your activity must also be modified in a way that will suit the environment in order to improve the patient participation. Why I'm saying this? One, if there is any problem at any point that affects the brain component, and in turn that leads to a deficit in terms of motor control of a patient in any kind of activity, there is need for us to go into the retraining part. And in order to do the retraining, there are some components of human body function that are very essential to motor learning principles. Number one is that yesterday, during when Mr. Solomon was presenting on neuroplasticity and direction towards recovery, he made us he helped us to understand what action system is all about, the role of motor cortex, the role of basal ganglia in terms of memory, the cerebellum, and all other components that has to do with motor component, how they help patients in order to regain function. But in order to add to that, I want you to understand that we have a sensory and perceptual component, which are also very essential to retraining a patient after deficit. All the senses that we have, be it the touch sense, the auditory sense, the visual sense, the taste sense, the olfactory sense for smell, as well as the joint sense, are very important whenever you want to retrain a patient after motor control deficit. Now, to achieve any of your intervention principles, you know that there is need for you to present, you need to present an activity to a patient. While presenting an activity, the senses are the receptors area, which you expect the patient to catch the information that you are trying to pass across. And from there, you expect assimilation and training goes on and on. So these systems are very important and you must take into consideration. Now, in terms of motor learning on its own, whenever there is a deficit in motor control function, you expect during rehabilitation phase, you expect that patient to be retrained on how to achieve that lost deficit using the concept of neuroplasticity, but with variety of mechanisms. So learning involves different dimensions. And if you see in this definition that there is a word that talks about process associated with practice or experience that relatively leads to permanent changes. The experience is one thing that we were arguing out yesterday about muscle memory and how it helps to, when there's an adult something, then the patient tends to achieve more better because they have learned that particular skills and the muscles has get used to that skill. So you cannot justify the improvement of that kind of that's the kind of a patient with a pediatric population who has not learned any skill, talk less of knowing what deficit is all about. So motor learning swing in both phase. It works for both pediatric as well as an adult case. So whichever way, the goals lies in the hands of the therapist presentation of the activities. Moving forward from, there are some theories which help us to understand the concept of motor learning. Number one that I'm going to mention to us is the gentle two stages model. This theory helps us to understand how an ideal movement can be produced and how that movement can help us to achieve a better improvement in our patient. The other part of it that I would like to talk about is the neural theory, which talks about understanding basic pattern of movement and coordination. Then we have another theory, which we are still going to talk about in details later. And that is all about the cognitive and associative stages of learning, basically learning stages by Fitz and Potsnier. We have the Adams theory. We have the three stages model, which talks about degree of freedom that we have. And as I've mentioned before, taking a glass of water alone into the mouth requires some degree of movement in different joints. So we need to understand when there is a deficit, how do we attend to the patient? What degree of movement is that joint lacking? And then how many effort do we need to place on it in order to remediate? So the last that I'll mention is the Smith schema theory, which emphasizes more on the need and the use of sensory input during your rehabilitation. Moving forward, for a patient to achieve some certain goals during practice, using the concept of neuroplasticity in motor learning, there is always a practice level. The level talks in terms of how many practice amount do we need to engage a patient before we expect an outcome or a functional outcome. There are a variety of theories around this, and so many studies have been conducted in order to answer this particular question. But if you look on your screen, you see that I've mentioned three major studies here. These studies are very old. I choose them because most of the existing and the new theories that we have now were actually detailing more on these particular three studies. So the first theory was conducted in 1899 by Bryan on how to use a telegraphic. So the patient that participated in this practiced that skill for almost 18 months before they were able to get an adaptation level and able to practice and perform that independently. There was another study by Snoddy in 1926 on how to use the practice of drawings on a mirror. This page, the group of participants that participated in this, it was actually an experimental study that was done through randomized control trial. It took them 100 days to achieve that particular level of function. Then there was another one about cigar rolling. The group of patients that participated in this Crossman study in 1959, it took them 7 years before they achieved some level of performance in terms of cigar rolling. So having said this tells you that individual improvement lies in the hands of the nature of the condition, the learning stage or ability of that patient, and the intervention process of the therapist. So in conclusion, whenever you are starting your intervention with your patient, improvement at the initial stage might be large. You might see some unjustified improvement at the beginning, but as time goes on, as practice is being refined, that will become very minute. Also, the more you practice, the more you engage or involve your patient in your session, the better they learn or they relearn the lost deficit. Then there is always an improvement in performance after many years of practice. So a rehabilitation does not only focus on one day or weeks or month. It's a long-term process depending on the functional stage of that patient. Now, let's quickly talk about stages of learning. The stages of learning are very essential to patient achievement or accomplishment of a specific goals. When you are setting a goal for your patient, first thing that you need to consider is that what stage of learning is my patient? Once you're able to decipher this information, it helps you to know how to break your activity down into components that will be achievable by that patient, and what you will not be overwhelming the patient in too many or too much activity that might be more than what is required of them. So we have a cognitive stage, which is the very least. We have some patients functioning at intermediate, and we have some which are at advanced or automatic stage. The way an automatic performing patient will achieve a particular activity, the weeks, the days, the number, the intensity, the duration will be quite different from the way same patient that function at beginner or cognitive stage will achieve that same skill. So we need to take note of this. Moving forward, for you to achieve any level of functional outcome in the stages of learning or doing your retraining, there is a concept behind this. That concept is the neurophysiological basis behind achievement or your patient improvement. Yesterday, when you learned about the neuroplasticity concept, for memory information, this is the act of neuroplasticity and how the brain rewire itself and tap additional connections from other functioning part of the brain. So that concept is known as engram formation, in general word, memory trace. So the concept of memory trace lies in the short-term memory as well as the working memory. Whenever we are able to facilitate this memory trace, then it gives us an ability to take that patient into adaptation of that particular skill. Please, I want you to pay attention to this particular concept because it will be the grand foundation of how we are going to be implementing our random and block practice. Now, in the brain, we have a group of cells known as the revibrating cells assemblies. These cells are essential for memories. These cells have a multiple interneuronal connections. So whenever there is a deficit in motor control, you need a multiple training in order to activate this particular revibrating cells. Once you're able to activate their function, the patient will save that particular task that you are presenting to them in short-term memory. I repeat, you present a certain activity to the patient, activities such as drinking water. It requires some level of practice before the patient will be able to do that activity. But once the patient is able to do it during the therapy session, that means there is an information that has spiked the revibrating cells assembly that gets that information to be stored temporarily inside the short-term memory. And that's why you see that sometimes your patient will perform well during your therapy session, but as soon as they get home, the parent will come back or whatever it is, they will come back and let you know that this patient was not able to do this again and again and again. Even if you yourself present same activity to your patient, he or she might still find it difficult to participate in that same. So that tells you that Once it's in short-term memory and there's no continuation in terms of excitation, the patient will lose it again, and it required another level of revibration cells excitation. Now, this, what I'm explaining to you, serve as the neurophysiological basis behind consolidation or behind retraining. Moving forward, I mentioned this yesterday that every cortical cells has about 4,000 to 10,000 interneuronal connections. That tells us that even with deficit in a patient, that same patient with deficit still have an ability to be retrained and to gain more information, because some other cells are there that are ready to compensate for the deficit. But what is lacking in that sequence is the implementation or something to spark up that activation so that the patient can engage in that particular skills. So according to various studies, but the most recent and well acceptable study says that it needs almost thousands of repetition in one particular task before you can form a memory trace or an engram formation. When a patient forms this memory trace, as I said, that trace will be saved in the short-term memory for a very limited time. So that tells you that during your practice, your patient might be able to perform some certain activity due to the concept of the memory trace. But for you to take that patient to adaptation level, you want them to be able to do it independently, you need multiple practice that might take up to millions. Some studies say 3 millions at least minimum of practice of that same skill in a perfect practice before you expect adaptation and perfection in that particular skills in the patient. What I've explained to you is the ground basis of our training and patient achievement of specific skills. Now, in terms of practice, practice is one tool that we use as an occupational therapist while we are involving our patient. But there are some laws that guide practice. One good law says that improvement in performance will continue as long as you continue to practice with the patient. You should know now that your practice is to spark up the activation of the memory trace when you are going with the concept of neuroplasticity. And then the more you do, the better the patient achieve. And please know that practice will never automatically lead to learning. You might practice with patient or get patient involved and still they would not learn that particular skill when the skills are presented in a manner that doesn't address the learning stage of the patient. Away from that, there are two classifications of practice during therapy. Number one is what is known as perfect practice. When you practice perfect practice, it means that you are practicing errorless concept. The therapy, the language of instruction is very clear. Patient participation is at optimum best, and you as a therapist, patient is not distracted, not overwhelming, and the likes. So it leads to skills acquisition, better performance on task, and adaptation. And the biggest of all, the perfect practice takes your patient faster to performance adaptation. What I mean is that the patient should be able to perform that particular skills that you are training in them in different areas, either at schools, hospitals, clinic, rehab centers, wherever they met themselves. So the second phase of practice is what is known as deliberate practice. Deliberate practice is more or less like forcing a patient to get engaged or involved in a particular skills that you as a therapist know that will be of better, it will support their improvement. It's not usually enjoyable and it might be stressful to the patient and to you as a therapist. But deliberate practice gives you more insight on performance on task. What I mean by performance on task, in motor learning theory concept, when a patient is able to show you some levels of improvement during your practice or during your training, that is not adaptation. If the patient can perform that same skills at any other location, then it is adaptation. But when the patient only show improvement during therapy session, That is performance on task, which does not mean that patients are learning it maximally. Now, the performance on task can be achieved mostly with deliberate practice. Away from that, there are different dimensions into motor learning theories, but for purpose of today's presentation, we are going to be limiting ourselves to random and block practice. So probably some other days we might consider other ones if there is need for that. But before we go into that, I would like to bring to you the concept of the contextual interference, which is very necessary when we are talking about block and random practice. They are the ways the task has been presented. So the nature and the random presentation of our therapy activities in one particular session, meaning that I want to engage a patient in one session, whatever tools that I want to use and the activity that I want to present to the patient, all this will come in contextual interference, the context at which that practice wants to be practiced. It was introduced in 1990 and introduced fully into motor learning theories in 2003. Until date, there has been a lot of emphasis on it. Why am I telling you this? Block and random practice, they create different levels of contextual interference, contextual practice miss. Now, the one that created the lowest contextual interference, that when you engage a patient in this practice within a certain setting, it leads to a very less improvement. That one is known as the block practice. It gives the lowest level of contextual interference. The one that gives us the highest happens to be the random practice. And we have the one that falls within the middle, which is the moderate level, and that's given by serial practice. But for today, I'm not going to deal more with serial practice. I'm just going to talk more on block and random practice. Now, understanding block and random practice, in our intervention as an occupational therapist, when you are going with neuro rehabilitation, there's something known as inter-skills practice or between skill practice. Any skills that involve multiple activities which will be practiced as a predetermined or unpredetermined illustration. This comes under the axis of scheduled inter-skill practice. So now let's go in details about what block practice is all about. Block practice as a concept is the arrangement of a skills sequentially in some predetermined order. So I want to involve my patient in 5 tasks. That task will have been arranged as 1, 2, 3, 4, 5. The practice skills will require some specific number of trials. So if I'm practicing skills A 5 times, I have to practice skills B 5 times, C, E, and like on and on each same time. And you must complete one task before you move on to another task. When we say complete, it means that you should expect some level of performance in patient before you move on to the next task. So there are concepts around that. The first concept that I want you to understand is that individual skills in block practice are arranged in isolation. You don't mix 2 activities on a table. If I'm practicing with a patient with 5 activities, one activity will only be on my table at a time with my patient. When you give one activity, that gives room for the patient to block out all effect or distraction from other activities, and their performance, all their attentions, their focus will be on one particular skills, which give a better assimilation. So that assimilation is what they will use in order to form the memory trace, which we need for them to get along with that concept. Now, the rationale behind that is that for patients to achieve a performance in block practice, there is, or in any of the motor learning theory, there is what is known as the action plan reconstruction concept or principle. The first point on that is what we call as forgetting hypothesis. The forgetting hypothesis is what we use to train or to bring about the spiking or the excitation of the memory trace. So that says that when you present an activity A to a patient, out of 5, the patient might show you some performance in that A. But immediately if you present activity B, the patient will sieve out the activity A in order to make room for the activity B that you are introducing in the memory space. So again, I told you that the A will be stored in the short-term memory. So when you bring B, the patient sieve out A and learn the B. When you bring C, the patient sieve A and B away and then learn C. When you bring D, the patient leaves A, B, C and then learn D. At the end of the day, if the patient presents to you again next session, that patient would have even lost A, B, C, D completely. And then again, you have to start afresh. So this is the action plan reconstruction. And that is why the block practice is given a very lower contextual, very lower contextual interference, because they keep forgetting, you bring new one, they keep forgetting, and on like that. Unlike what we are going to learn in random practice. Okay, let me give you a few examples. If we present an activity to a patient, such as combing, buttoning, and handwriting, the block schedule of that activity will be that if I want the patient to practice the combing 5 times, so it will be A. After achieving some performance, then I go to buttoning of shirt, which must be done 5 times because A was practiced 5 times. Same thing goes with C. And please note that each skills will be practiced and the same number of trial must be maximized. The drawback in this is that the patient might not retain that skills, or there might be little to no transfer. As you know that it's working with the short-term memory, and the more you load the patient, the more the patient forget more. So the next line of action here is that just look at this picture. If I'm presenting an activity to a patient in the form of a block, I'm using this as an example. We are still going to deal with the practical aspect of it. The A will be presented separately. When the patient shows some maximum level of performance, I go to B, then I go to C, then I go to D. Again, take an insight of this activity that you are seeing. If we are to engage a patient and activity were presented on a table in this format, all what we want the patient to do is there at once. This might be overwhelming, and this is not a better way to engage a block practice techniques. If you really want to go with the concept of block practice, one activity must be introduced to the patient at a time before presenting the next activities. And make sure that the patient achieves some level of performance in terms of repetition before you move on to the next. And the same repetition amount must be optimized in every patient. So I quickly want to give you a small video just to see how sometimes we can implement or arrange our activity depending on how functioning is the learning stage of our patient. If you see in this video, the activity has been introduced to the patient, and this patient is going to engage in 5 different activities with the names. And this patient, for your information, is a mental health patient that is functioning at an advanced stage. So if it is advanced stage, even when you present multiple tasks in block separately, the patient can still pay attention to each task without getting distracted. So the patient is involving in the activity separately because this was arranged because the patient was functioning at advanced learning. So without no distraction, and the patient is able to follow the sequence. So, and the video was not taken in the first day. This was after some numbers of intervention, and the patient has improved up to this level. So all the 5 activities were presented to the patient, and the patient is meant to practice one, then move on to the next. So this is one way towards presenting our activity. And I want you to understand that this was not because the patient is at advanced learning stage. So if the patient is at the beginner, each activity will have been presented separately, taking away other ones. Away from that, this is another quick illustration. If you look at this, you can see that sorry. Okay. If you look at what I want to show you, four different activities were presented on the table, and the child is expected to practice each skills separately in a block fashion in order to enhance some level of participation. This same patient, if you can see carefully that we have implemented the concept of modified constraint-induced movement therapy. The patient is CP, diplegic, so we reduce the useful. We try to reduce its usefulness of the non-affected hand with a sling, using the mother's cloth during the therapy session, and over a repetition of practice. Initially, the patient was not interested. We tried to use perfect practice, it wasn't work. We come in with axis of deliberate practice, which needs some level of promptness. At the end of it, after some few sessions, this same patient was able to started practicing that skills using the deficit hand during a session in a very block format, one activity at a time, then we move on to the next. So that is one way. Now, let's quickly talk about random practice. Random practice is a way of presenting several skills in one single session in a randomized and unpredictable order. Unlike what we have in block practice, it's well predetermined. You already have your arrangement. You know how you want to flow as A, B, C. But in random practice, you might have A, B, C, D as an activity, but you don't choose where to start. The patient or you can choose to start at C and then go back to B, come back to A. So, and the other thing is that practice are mixed, and you never practice same skills twice. Once you practice B, you move on to the next. You don't do B, B, B. Like what we have in block practice, where you can do A for some certain amount of numbers. In block, you might do B, you go back to A, you do C, you can come back to B, but you never practice same skills at the same time. Under this, the action plan reconstruction, which is the physiological basis behind the memory trace, says that there is something known as retrieval practice. When you present an activity to a patient as B, the patient learns that as soon as you present another activity as C, the patient forgets what that B is and learn the C. But because you are presenting the activity in a randomized order, B, then you go to A, you go to C, you come back to A, you come back to B, the patient that gives the patient an opportunity to learn, forget it. Then as soon as you present it again, he learns it, forget it, he will learn, forget. So that concept of learning and forget spike up the working memory from the short-term memory in order for the patient to master that skills. Because the more they forget, you learn, you teach. Again, forget, you teach. You forget, you teach. Unlike in block, that the patient forgets, and then you present another one, you move on. But in this, as soon as you present it, the B, the patient forgets, you bring A on board. So this gives a better outcome and transfer of skills over time. So in that, if you present an activity during your practice trial as B, C, A, C, B, B, A, C, B, C, A, D, and like that. So compared to block practice that present an activity, this gives an immediate challenge to the patient, which will be addressed by you as well as the patient simultaneously. And that concept of retrieval practice help the patient to achieve best during block practice. But how do you supposed to use these techniques as an occupational therapist? The skill is very simple and easy. For me as a practitioner, in my practice, I've been able to explore this. And based on different field of practice and studies also, there has been a lot of argument on how to implement this. But the best and the most accepted order by scholars is that whenever you are starting with a patient, start with some block presentation. Present your activity in form of a block to the point that the patient forms the initial memory trace. Remember, memory trace need at least 100 repetition of that skills. But when you want to talk about the transfers and adaptation, once the patient show you some level of performance on task that I can do, I can try, then quickly switch the activity that you are engaging the patient in block to random order. So when you go in random order, that gives the patient an ability to generalize that skills and use the the retrieval practice techniques in order to master it and transfer that skills. So basically, you start with some element of block practice. From block practice, once you see some performance on task, transfer that same activity that you are engaging your patient into random order. Please note, there is no exact amount of prescription or numbers of practice that is yet being ascertained by literatures or by research. So the study still goes on, and it's open for me and you to also tap into. Away from that, there are some myths around block practice, and I just want us to understand that it can mislead us as a therapist, because when patients show performance on task, if therapist doesn't understand what I've been saying, you think you are working or your patient is improving. Rather, your patient is not improving. It's more to your own effort. When you are going with the initial practice of block, using either deliberate or perfect practice, you as a therapist do almost 50% of the task. The patient only contributes 25%, and the remaining 25 is room for error. So with this, more times patients don't achieve a better outcome, but at the initial stage, you might think you're working efficiently. Also, another thing I want you to learn is that when you engage a patient in random practice, the concept of learning and relearning, learning and forgetting, relearning and forgetting can make patients to be frustrated. And then it's also frustrating to us as the therapist. But don't think the patient is not gaining. The patient is gaining and they are learning. So you need to be very fast with that and understand that concept. Away from that, we have what is known as practice distribution. During your practice of block or random, there are ways we present the task, and there are certain amount of time that is required to practice, and there's some time that is required for you to give the patient some rest moment. So we have distributed and max practice. Distributed involve long period of rest than practice. This is more ideal when you are engaging a patient in random practice. You give them more room to forget it, and then you can retrain it. So which will help them to achieve a better adaptation. But mass practice is very necessary whenever you are using your block practice, because you give the patient less time on rest and you make them to work more. So that's one concept that I want you to learn. There has been a lot of evidence around block and random practice. A group of stroke patients has benefited from block and random practice in a study conducted by Hanslow in 1996, Alzheimer's disease by Dix in 2000, children with Down syndrome by various studies, Edward, Elliott, and Lee. All these have conducted different studies, and there are improvements in all the patients. So this is to tell you that the skills and the therapy works, irrespective of the condition. It just lies on the hand of therapists, how you present it and your concept of engaging your patient. So away from that, there are some skills that are very necessary whenever we are engaging our patient in block and random practice. These skills are known as variations in block and random practice. Please, for the therapists that are listening to me, these are the tools that we use whenever we are engaging our patient using this concept. If you don't understand this concept, definitely you cannot practice these techniques efficiently. Number one is the concept of fragmentation. We have segmentation, attention cueing, and task simplification. So I will take them one after the other. All these skills comes under the axis of what is known as part practice. And in fragmentation, it is skills that involve execution simultaneously. If there is an activity that you're supposed to do at once, and the patient is showing you some deficit in that, the concept that is best for you to use to engage your patient is fragmentation. But segmentation is to be used when an activity can be broken down into smaller components. Activities such as brushing require some steps. So segmentation is the best in that concept. Now, let's take them one after the other. This is not a patient, it is me. But I just use this so that we all can understand how to implement this. Not necessarily confined to botany or whatever I'm going to be showing you. You can come up with it within another dimension of activity, but just understand this concept. In fragmentation, therapists will do half or 50% of the task. Remember, if your patient is functioning at cognitive stage, let's say advanced learning stage, therapists will do 75% of the task. But if your patient is at intermediate, you do 50%. But when your patient is beginner, you only do 75% and you allow the patient to continue or to complete the task. Bottling is an activity that requires simultaneous movement, but you know that your patient might not get it. So you have to do some level of some levels, and then you prompt the patient to complete the task. Over time, you fade out your own amount of impact. So if you are giving 75% at the, 25% at the beginning, 75 at the beginning, once you see some level of improvement in patient, you reduce it to 50, then to 25, to the point that you expect the patient to be able to show you some performance adaptation, task adaptation. So this is another one on how to don a socks. Assuming this patient is functioning at an intermediate, which is associative, I'm going to do 50% of the socks, and then I expect the patient to complete the rest of the task, making it 100%. So this is how to go with your fragmentation. It can be done on any kind of activity. You just understand what you want to do, the stages of learning of your patient, and then you implement. This is another one. For the purpose of the participant, all the patients in this video, I've given their consent and they allow me to go ahead using the video, although I try to protect them still, but for some mix-up that you might see. So we already have a consent to use them already from them. Now, this is a patient, a stroke patient. This patient was has already been trained on how to use the concept of fragmentation, and on how to don a shirt. So the patient has achieved some performance on task and some adaptation. So you can see that when the therapist presents the shirt to the patient, he tried to drag the hand into the affected limb first because he has understood the concept of fragmentation. The therapist here only performed less than 5% of the action, and the patient completed the 95%. So that shows you that this particular concept works and all patients can benefit from it. The next point is the segmentation. Activity that can be done, that have component, can be better achieved in concept of segmentation. So you need to get the activity into stages that the patient will be able to achieve or accomplish. But segmentation is of two different types. We have what is known as repetitive part, when an activity required a sequence, a continual sequence. A continuous steps. And the progressive part is when an activity required a sequence that you have to keep doing. Activities such as brushing a teeth required more of repetition, but an activity that has to do with beading needs more of progressive. So in this, just see this patient. Oh, sorry for that. The patient is expected to pick a bead from a Play-Doh. That bead will be dropped inside a container. If you are going with your block or random practice, the patient picks the bead with a certain amount of time in sequence. The bead cannot be taken at once. It requires the patient to pick it one at a time. So that is more too repetitive. This same concept can be taken back to ADL or any things that you are training in your patient, but the goal lies in you as a therapist to understand which concept am I using and how am I using it. The next one here is the progressive part. This patient is engaging in bead stringing, and you can see it's a continual process that needs the patient to be doing it on a continual chain for as long as you want. If I only want my patient to do this bead stringing for 100 times, that means I have to present 100 of it. And then you expect the patient to do that before we move on to another task. Please note, this can be used either when you are training random or block practice. The other side is attention cueing. This patient that you are seeing, he needs to pick the peg and precisely fix it in a certain hole. That requires some level of attention focus on that particular task. In other words, this attention cueing tells you that you need to sieve out all of that distraction, all of that distracting element in that patient. But when your patient functions at an advanced stage that doesn't have much challenge with attention span, then you can still consider the activity in this dimension. And this is more towards a progressive kind of cueing activities. The patient needs to complete the task as a process in order of presentation. So moving forward, tasks can be simplified in 5 different concepts. One is for us as a therapist to reduce the difficulty of the object of the activities. Make sure that the attention demand of the task is not too much overwhelming. The speed of participation of the patient might be too low. It's either we increase it or we try to reduce it for patient to achieve it. We can add auditive cueing or any other cueing. Clapping is a cue. Giving the patient some level of can we stop annotating, please? So giving an using an activity such as thumbs up, good job, great work, which are verbal prompts and all those things can also help your patient to achieve that particular task. Make sure the sequence of the skills are in progression of what the patient will achieve. And there has been a lot of studies about this with OT practice with a better improvement. The last was in 2013, and it was a very successful practice techniques. So in order for us to achieve the task simplification as a concept, we need to understand the concept of task complexity and organization, which talks about how we present a task to our patient and what we intend to achieve in them. Tasks could be high in complexity and low in organization. Sometimes it could be high in either, and it could be high in complexity, but low in organization, low in complexity and high in organization. Irrespective of the nature, we need to understand what is the learning stages of our patient, what am I trying to train in this patient, and in that manner, you now need to present the task in a manner that the patient will be able to achieve it. Now, let's take a look at this puzzle. If you see this puzzle, it required a child of 3 years to first sort out the alphabet, then arrange the pictures, then fix it in order. And then you have multiple of it. If you present this kind of a task to a child that is less than 5, the complexity will be too high. The organization as well will be too high. Please, this does not delimit alone to the puzzle. It's just trying to give you an idea of how you present a task to your patient. So if you are training eating, that means if you present spoon, fork, knife, all the cutleries, and then the cup, everything at once to a patient that is functioning at a beginner, that patient might find it too overwhelming and he will not learn anything at the end of the day. Now, let's compare this with, okay, this is another high complexity and organization. For a child that is less than 10, if you present a kind of a task like this that require them to first engage in beading, then go down to skip roping, they need to assemble the colors and then do the painting. They need to cut on a straight line. This might be too challenging at once, but if you present it in a block and a very simplified way of one task at a moment, after accomplishing that, you move on to the next. Compare that to this particular arrangement. This task is high in complexity, but very low in organization. For a child of 3 years of age, what he or she needs to do is just to flip this over and fix it. But the complexity is the organization is very low, but the complexity here is that it will have been better if we present only A alphabet and apple. That gives the child a better opportunity to fix it. Then you introduce B and the ball. But when you present 5 at a time for a child of 3, just imagine the complexity will be too high because the child might be overwhelmed and get distracted of where to start, and at the end of the day messed up all the entire puzzles. This is another one that shows more of low complexity but high in organization. You see that this is very easy for a child of 3 years to fix. It's just to merge the two and then fix the puzzle. But the complexity is very less, just to merge it. But the organization is high because we are presenting 5 tasks at a time to a child of 3 years. So if to say that we only have, you present A, then you move on to B to C, it would have been low in complexity and low in organization. Having said that, I quickly play a video. It's for about 5 minutes and I want you to be patient, which will be, I'm winding down now. So that video has all the elements of the activities and whatever I've been saying. And I will be giving some quick verbal prompt along the video. So first of all, sorry for the poor quality in terms of the video. Yes, so subsequent ones will be better. Now, we are starting with block practice. And under that, we are considering the segmentation repetitive part first. If you see this, the therapist presents the activity to the patient one at a time in the form of a segmentation, and we are doing the repetitive part. This patient is expected to do this activity for 4 sequences. So that means each activity we are going to practice letter A, B, C, and D. Each are supposed to be practiced in 4 repetitions or 4 trials. So the patient has completed the first part. The second part, you see that the patient completed it, the therapist reintroduce that same activity so that the patient can first achieve some level of performance in it before moving on to the next. Remember, this is block concept in form of a segmental repetitive part. Now on to C. Same amount of practice, same amount of effort, same concept, never change the steps. So whatever concept you are going with, you have to maintain it and make sure your patient achieve what you want before you move on to the next task. Oh, I'm very sorry for that. So the therapist is trying to increase the complexity to some extent. Now, we move on to segmentation, progressive part. As compared to what you see in repetitive part, you see that this patient, as soon as he completed A, the therapist does not introduce same activity. Rather, she moves on to the next activity, and that activity goes on and on. So now, this same patient is expected to practice A, B, C, D, as in what he practiced in repetitive part. But the twist around segmented part is that as soon as the patient completed, so here now, A, B, C, D will serve as one. So the patient must complete A, B, C, D before you reintroduce that same activity. So you don't repeat it immediately. You allow the patient to complete that particular activity, then you reintroduce it so that you can, this will give the patient a better way of practicing that skills to form some level of memory trace before moving on to the next task. So the patient practice this on and on. So this is the clear, distinct difference between repetitive and repetitive segmentation and progressive segmentation. So when you talk about attention cueing, you just want the patient to pay attention to one particular task at a time before moving on to the next. So I'm using the activity of coloring in this. Please note that I choose this because it's more easy for me to pass across. But these particular techniques can be used when you are dealing with any variety of your activities. You just need to understand the concept, and this is just to give you an idea about what it is and how to implement them. So it's not left for you as a therapist to use your pragmatic reasoning whenever you are engaging with your patient, and make sure the activities that you want to engage the patient are structured in this dimension. So this patient, we have to do one color at a time. After completing one particular color, the therapist can then introduce, you see that the patient was allowed to complete that. Then the therapist introduced green color. So now that all the colors were presented, please, this is best when the patient is functioning at a very beginner learning stage. If it's an advanced, you might choose to present the two colors at the same time, and you expect the patient to engage. For purpose of time, allow me to bite it a bit. So the patient practice that. Okay. So we have the other side, which is fragnation, which is another concept in our variation, in our practice variation. So what fragnation says is that whenever you are engaging a patient, first take into consideration of the patient functional level, as well as how to break the activity into smaller bits. So you want this patient, the activity of brushing required a simultaneous action. The patient is supposed to wet the brush, apply the paste, and then go on with the brushing, then wipe them out. But when you are using block or random practice, you first of all have to present each steps of brushing in form of a fragment to the patient. And you expect the patient to practice that fragnation for same amount of time. I want to show you brush. You might show the brush 3 times. I want to show you cup and how to wet brush 3 times. I want to show you how to apply paste 3 times, then how to brush in 3 different sequences. So the patient goes on and do the brushing. If you train the patient on how to wet the brush in 3 sequences, make sure that the brushing that the patient will practice also must be for 3 sequences, not less. Even wiping the mouth must also be 3 sequences, you should not reduce the number. Now, in terms of random practice, I consider A and B. The A part, you see all the activity were presented to the patient at once in form of a randomization. So I expect the patient to start with whatever they think they want to start with. So this patient have choose to start with brushing. The brushing, whatever concept you are using, either fragmentation, segmentation, simplification, you must maintain same amount of practice level. The patient has completed the activity of brushing, just like that. Then he or she choose to go for coloring, which is another activity being presented to him. Completed, and then onto the puzzle. So unlike in block, that the first component was the puzzle, then the patient do the drawing and go to the most complex one, which is the brushing. But here, the patient choose to start with what they think they are okay with. So for the B part, this is a practice. If you look at this patient, we presented the patient, we presented a refined task to the patient in a word, and the patient was able to get the concept after some level of practice. You see that the patient was the one that helped us to remove the plate inside that tray to give room for her to peel the potato. This patient has Guillain-Barré syndrome, and she has some balance challenge, which we are trying to retrain using this concept. So what we bring, I mean, the randomization here is that the patient was the one that chose to first remove the plate, pick the potato, then grabs the peeler, and then move on with the task. So right, in some cases, if this patient is not conversant with that, he or she might need some block presentation of how to start and what to start with. But for the fact that the patient has been trained over time, she was able to do this. And the reason we choose this concept was that we want to train the balance, and while peeling the potato in standing, the patient attention was on what she's doing rather than the balance issue. So she keeps swaying around, which helped to improve the balance. And also the sensory feedback was why we presented the activity, because we want her to be able to grasp and make some movement. So this is a tactical illustration of how we can practice block and random practice as an OT. But after our practice, how do we document our patient progress, our intervention session, going with the concept of block and random and then neuroplasticity? First and foremost, after our assessment as an occupational therapist, you need to list out the problems that we know that are very essential to the patient. Here, I consider 5 activities as more essential to the patient. One is that this patient has deficit in toothbrushing, in upper body dressing, posture fixing, drawing and painting, and then cooking. So what type of practice method do you want to engage your patient? I choose to go with block, then practice techniques. So for teeth brushing, I'm going with segmentation. For upper body, I want to use fragmentation. For puzzle fixing, I'm going with segmentation and repetitive part. Then attentional cueing for drawing. Then for cooking, I'm going with segmentation and then a progressive part. Please, if you can see this, these are what you are supposed to do after your assessment, after your assessment and your treatment intervention plan, before you start treating your patient, so that you don't go wrong at any point. Your skills are well spelled out, your techniques, everything is well explicit. So you understand it, you can communicate this better with your patient. So the repetition amount that I want to use, 3, 3, 5, 3. For cooking, I'm going with 1. So for how long do I want to practice that particular skill? For teeth brushing, for 5 minutes. For upper body dressing, 2 minutes. For cooking, I'm going with 15 minutes. Now, the learning level of my patient, these are just being presented in a random order. I just choose to do that. So I go with cognitive, associative, automatic, and like that. So the randomization here is that if I have to, after patient show me some level of performance, then I want to randomize it. I might choose activity 1 to 5 as my task. What practice method I go with randomization? What practice techniques, any of the techniques mentioned here that I know that suit the patient, I go with it. And how many amount of repetition, that depends on what I want to do with the patient. For how long? In random now, it's not specific to each task. And remember, one task will not be presented same time. So I go with 40 minutes. So the patient could be at any level of performance. But for purpose of practitioners on this platform, after your session, know that you must give performance remark at the end of each session. That will help you to trace the patient functional level. So with this, allow me to wind down and take a rest so that the moderator will take over and then we can take the question and answer session. And I hope I've been able to communicate a bit what block and random practice is all about. Thank you.
Thank you so much, Mr. Abiodun. That was so insightful. I had a lot I'd noted down. Well, and it was very, very, very informative, very relatable. We were, I was able to, well, personally, because I work with kids, well, I used to, now I work with a young adult, but, working with kids, I was able to bring this back to when I, working with children, even in school, when you're teaching them some skills or, example is when you have a child with, a poor coordination, and eye-hand coordination and the likes, and you're trying to use some activities in class to achieve, progress. So yes, I was just remembering all of these things, and yes, very relatable, very straight to point and practical. Thank you so much. That was so beautiful. All right, so now we are in the question and answer session. If you have any question, you can use any of the reactions to state your, to indicate your interest, to ask the speaker a question. And also with the speaker this afternoon, we have two panel members. We have Mr. Kehinde Jopamu, who is the panelist one. You will see his name as panelist one. And we have Mr. Emmanuel Olukoju, the panelist two, who will be answering questions together with the speaker. So speaker would be answering questions, and if further clarification or, would the panel members would be there, and any other person would love to contribute, just indicate. I have everyone on mute at the moment, but then I'm going to give you the permission to unmute. But if you're not speaking, kindly, kindly keep yourself on mute so that we do not have, all right. So I'm allowing everyone to unmute now. Okay, so to start off, whilst we're waiting for people to ask questions, I have a couple of questions that I noted down from the speaker and the panel members. If you have further questions, you could drop them in the chat or raise your hand or give a thumbs up. When I see a reaction, I will know that you need our attention. So I'd respond to you immediately. All right. So whilst we're waiting for questions to come in, I have someone who's asked question in the chat, Epiphany, but I'll get to you, Epiphany. So quickly, Mr. Abiodun, this question is directed to you. I'll set the pace, just like yesterday, Mr. Karim set the pace for the question and answer. So I'll set the pace too. And then if you have, and after that, every other person can come on to ask questions. You can drop it in the chat or leave a reaction. All right. So quickly, Mr. Abiodun, you made mention of, I think the first 20 minutes or into the training, you made mention, I see you, Mr. Joseph, I'll get to you. Thank you. You made mention, you said practice does not necessarily leads to learning. So my question now is, how do you tailor the practice, or you tailor the therapy towards learning and acquisition of the skill, in general? How do I make sure that whatever I am doing, whatever technique I am doing, I'm fashioning it towards learning and the acquisition of that skill, complete acquisition, not just learning, not just practicing a skill directed at recovery, but you want that skill to be inherent, you want that client to own the skill. How do I fashion that? How do I tailor in that direction? Okay. Oh, okay, thank you. You're on mute.
Thank you, Ms. Moderator, for that wonderful question. The concept there is that, I mean, the theory says that practice does not necessarily lead to learning, but whenever you want to engage a patient and you want your practice to lead to learning, there are a lot of other things that you need to consider. So one of such is that you see that I keep emphasizing on stages of learning.
Yes.
Every patient will not function at same level of function. And that is one wrongdoing that we as a therapist, we always engage with. We consider our patient as, all the patients are same. So far they are suffering same condition. But what this means is that whenever you are meeting any patient, you must be very sure of what is the condition, the nature of the condition, and to what extent can my patient learn, or how best can my patient learn. And if you see at the beginning, I mentioned some of the contributive factors that could assist us while we are training a patient. One of such is that your patient might be a visual learner, could be an auditory learner. So if a patient is an auditory learner, so to say, and your own focus was more to visual, you keep presenting an activity that has to do with seeing, your patient might tend not to achieve the optimum best. So that's why I said that whenever you are engaging in this, the pragmatic reason of a therapist is very, very essential. And our assessment must be well refined to actually bring about the main challenge and what are the better way of assisting such a child, and your patient will be able to learn best. So that's my contribution.
Thank you. Any of the panel members would like to add to that? Okay. All right. So thank you so much, Mr. Yusuph. So I have a question from Epiphany, but I would want Epiphany to unmute and ask. I couldn't comprehend the chat. So you may want to unmute and then ask your question directly. Epiphany, she was the first person who dropped a question in the chat.
Thank you.
Oh, you're welcome. All right.
Yes, I'm there. Thank you so much. Thank you, Mr. Yusuph, for the presentation. He showed us how client can participate in different tasks, showing client different tasks at the time. So now my question is, how if I hide my task or I don't show my task to my client, but I follow the sequence of the task? The example I mentioned was to engage a client in cleaning a table. After cleaning a table, washing the piece of clothes he used during the cleaning a table, and the last task is washing hands. So I have not used to tell my client the sequence of the task, but I have engaged him in the task. Thank you.
Did you get the question, Mr. Yusuph?
I think I do to some extent.
Okay.
I think what she's trying to, if I get you right, you're trying to ask that if you have, let's say like 3 different activities at a time, and you engage your patient in that same activity without informing the patient of the sequence and what you want the patients to do, right?
Yes.
Okay, this will definitely lead to a very poor outcome in your intervention. Why? Because if you look at the last, my last slide, which talks about documentation, the documentation process is supposed to be the first thing that you are supposed to draw out before engaging your patient, so that the patient, you yourself have a very clear view. I want my patient to do a table cleaning using this concept for this number of time, for this amount of practice. Same information will be communicated to your patient, and you'll be sure that he or she get the concept right. And you can now bring in your either perfect practice or deliberate practice, and you consider your distribution. What amount of rest did I want this patient to rest? What amount of effort did I want the patient to put into the task? And I will tell you, if you look at the entire structure of what I'm presenting, it's still focused on the client-centered practice. Your patient involvement is very paramount to the success of whatever they will achieve. So you should be able to first form the table, the documentation, and using that documentation, present it to your patient in a whichever way your patient learn, get along with the patient, and then you can now start initiating the practice. Never practice and then bring about the clarification. That will lead to a very poor outcome.
Yeah. Thank you.
All right. Thank you so much. Mr. Karim, you have your hands raised up. But whilst we're holding up on you, Mr. Abiodun, Joseph asked in the comment section, his question, he said, the differences in motor learning and motor control when it comes to practice, either blocked or random. I think he wants you to shed some more light, on that.
Okay. I think he joined late.
Okay.
When he talks about motor learning, motor control, the first part of it is motor control. So motor control says that there are so many components in human body function that help us to produce a certain desirable movement. And at the beginning, I give an example of drinking a water. When you want to drink a water, you need some component, some element of movement to be able to do that, which required your musculoskeletal system, your sensory system, your sight, and some other elements like that. Everything has to come together for you to be able to achieve this set goal of drinking water. But whenever there is a challenge or there is a problem affecting the motor control, probably due to any brain-related issues, and you want to retrain the lost deficit in that motor control, then you need to introduce the concept of motor learning, which gives more of the treatment version of what happens in motor control. So if you understand what happened, if you follow the presentation that we had yesterday by Mr. Solomon, you can see that there are different, the brain has the ability to regenerate is one concept, and also that there are some other part that whenever there is the deficit, the associated part that is very near or far to that area, there are some interneuronal connections that can spike up and then takes up the function. And this is what we target in motor relearning, to retrain the deficit component. So that's what I was saying that, Mr. Joseph.
Okay, thank you so much, Mr. Abiodun. Thank you so much. All right, so Mr. Karim, you have your hand raised up. Bring it down and go on to speak.
All right. Thank you, Mr. Speaker. You've really done a very wonderful job. What I actually raised my hand about is just to add like 1 or 2 points to the presentation that the speaker has made, which he made very eloquently. I just want to say that I said 2, right? Okay, 1 is that it's about the practice context. So I just want to add that when a client is allowed to practice in different contexts, it further enhances skill acquisition. It also further enhances, the transition of our client getting to that stage of, actually acquiring that skill and being able to practice the skill without the input of the therapist anymore. For example, let's imagine that the client has been able to do a particular activity in the clinic. That is one practice environment. Then the client is taken to maybe another room entirely, which is different from the particular room where he or she was trained initially. And the client is able to do the same activity using that same random practice. Even when we get to the client's home, we still train the client there. And then the client is able to transfer that skill home. The client has been able to practice in like 2 or 3 different contexts now, or environment now. That has been, studies have shown to, that enhances skill acquisition and retention. And that is one. Then the second thing I want to talk about is the fact that I still want to talk on that environment issue. That studies has also shown that when skill is being taught in a natural environment of the client, that it also still enhances skill acquisition better than when you train in a simulated environment, because simulated environment cannot be compared to natural one. It cannot be as rich as the natural one, because the natural one is the real situation or the real environment where the client is expected to operate. So when you train the clients more in their natural setting, they tend to be able to acquire the skill faster, and they'll be able to retain it for longer period of time. Thank you. Thank you.
Thank you so much, Mr. Karim. Thank you. We're waiting on for your questions. Still looking out for those with hands raised or any reaction that shows that you want to clarify. I remember that whilst okay, before I say anything, any of the panelists would like to add something? Okay, all right, Mr. Kenny, you may unmute yourself. Yes, Mr. Kenny, you can go ahead.
All right, good evening, everyone. Am I audible enough? It seems
Yes,
like my network has been bad. Okay, Mr. Speaker, you've done well. Thank you for the insight and the knowledge. I just want to add one or two things from the practical aspect of this whole thing. I work in a clinical setting, so there are some certain things you do as a clinician or a practicing occupational therapist that sometimes, maybe due to experiences, you don't know the theoretical basis for it, but you do them anyways. It's just to put them into perspective of that theory of it. Learning now or listening or going through the slides earlier gave me a perspective about some certain things I've been doing in my practice that is surprising to me that, okay, I've been using this block and random practice and so certain, what's it called, with some certain patients. I work with pediatrics patients majorly. And there's a particular patient I can remember vividly right now, whereby he's an athetoid CP patient, older patient. He talks and do some certain things. His functional level is a bit high for a cerebral palsy patient. And we do these things that to help sitting balance, straight leg sitting, and we pick from one, we pick objects or building blocks from one bowl to the other using right hand pick, transfer to the left hand, and then left hand drop to the other bowl. And then after that, after those repetitions, we move on to transition pattern from kneeling to pull to stand. You understand? We repeat those things, excuse me, at different times. And then when I discovered that he has gotten this skill, I now combine the two together. You sit, pick, kneel, pull to stand, and then drop, which means that initially I was practicing a block practice, doing a particular activity for a repetitive number of times for him to get it. And then at certain times, now go and bring water, stand up from a sitting position, pull to stand, and all like that. So I'm just trying to put some of this theoretical knowledge into practical perspective for some of our audience out there, that these are some of the things you might probably be engaged in that you don't know how to contextualize it. So thank you.
Yes, very true. Thank you, Mr. Kenny. Very, very true. Quite a number of times, well, more reason why we have this kind of trainings where we get to put theoretical appreciation to a lot of practical experiences or discharge of duties that we are involved in. A lot of times you see, oh, but I've been doing that thing. Oh, I've been doing this in that particular fashion. Oh, okay, so it's called a random practice. Oh, so it's called this. Okay, so that's why we bring ourselves at par with theoretical empirical studies and theoretical understanding of a lot of practices, techniques that we have been using over time, maybe due to your clinical reasoning or pragmatic sense of doing things. You get to do some things, you know, but you really do not know if there was a practical explanation, a theoretical explanation to it. So yes, this is one of the reasons why we do this kind of trainings. God bless. Thank you so much, speaker. Thank you so much. All right, so I don't know if we still have further questions. I'm yet to receive more, but I have more that I have noted down, and I'd like to ask the speaker and any other member of the panel that would be willing to respond. I remember that on the chat, the chat where you have documentation, the last slide, I think this is the last or second to the last slide where you have documentation. I saw that you add number of times allocated for number of repetition, number of duration of time for each skill, for different skills. Now, what informed that number of duration of time, you know, the particular duration of time was there a particular reason or, you know, a specific reason why 5 minutes was allotted for this, 15 minutes for cooking, 3 repetition trials for this, you know? Was there a particular reason to that? And I realized that, well, my understanding, you may want to correct, is that the stages of learning of the client will determine, you know, the number of time. However, was there a particular reason why 3 minutes, 4 minutes, 5 minutes was allotted?
Okay, thank you for that. You've actually answered the question.
Oh, okay.
Yes, the stages of learning inform that, and for whatever that I have on that slide was just for the purpose of this training. It was not specific to a particular patient. So the therapist needs to come up with what they think it's ideal for the patient. So if you practice that is not enough, then you can modify that or increase it or decrease whatever way you think it suits the practice. So that's just for the training. It doesn't matter. Yes.
All right. Thank you so much. Quick, another one. Pardon me. I'm going to bring this. Okay, Mr. Luko, do you want to say something?
Yes, thank you. I am sure you noticed I've been trying to unmute the speaker. Good evening, everybody. It's quite raining here and the network is terrible and no electricity to come on live. So sorry about that, but I've enjoyed the presentation, and in as much as I'm a freelance occupational therapist, in terms of in as much as I specify or I am more into pediatrics and mental health, neuro is always never out of it because it's embedded in our day-to-day practices and in terms of giving activities too. I also wanted to add to what the I think Mrs. Josephine, I'm not sure, she asked the question about giving an activity without the client's knowledge.
Epiphany.
Yes, okay. So in reaction to that, I would like to say it's important when we are formulating our treatments, goals and plan to carry the patient along, especially for documentation purpose, especially for medical legal issues, you know. Patients are supposed to know, clients are supposed to know, oh, we'll be doing this activity, and you know, and especially for billing purposes too, you know, depending whether you are working in a private as a private practitioner, private practice, or even with the government or in a hospital setting where you need to document, the patient and I agreed we are supposed to do certain activity. It's going to be there, probably maybe your first session, creating the rapport and psychoeducation of the patient. So, and other than that, it gives the patient or the client the feeling of togetherness as to the treatment they are doing. Oh, okay, we'll be moving this together. This is what we want to achieve, you know, and that informed too also helps in carrying out the activity, preparation of the brain cells, you know, all these activities, telling them is very, very important. Apart from the cues, apart from the random and blocks that we are doing, this helps to stimulate, you know, the clients in readiness to an activity. Thank you very, very much.
Thank you, Mr. Lukoji. Very true. Thank you so much. It allows. Oh, okay, Mr. Jean, Mrs. Jean. I think it's Jean. All right. Yeah, Jean-Claude. Yeah, I remember I had a friend with that spelling, and it's not, we call it, okay. Anyway, so I was saying that, you know, it makes clients take ownership when they are carried along. You know, working with young adults, you know, here, I realize that when you're formulating life plans, you're working with individualized plans for them. You have to, it has to be client centered. They have to tell you what they want on their plan. You cannot just say, because I am the professional here, or I have better experience here, so I think this is this. No, at some point they have to be well carried along, and you know, that's how they take ownership, and they give themselves towards progress that you, the professional, wants to see. They too want to see. They take ownership, and they, you know, they give themselves into that therapy or that treatment goal in the long run. Thank you so much. Yes, Mr. Jean, you may want to ask your questions. I have two questions to, you know, I noted down, but Mr. Jean-Claude, you may want to speak, please.
Thank you very much for, first of all, for the wonderful presentation you have had this evening. However, I want also to ask, building on the question that Ms. Epiphany has raised. So, of course, therapists try to bring out the points on it, but even myself, I want to add something. For instance, the previous speaker has said all about the reimbursement, documentation, whatever. However, when you do the assessment, you highlighted the challenges you've seen from the patient. Then with the patient, you set the goals. So when you're setting the goal, of course, you argue on the means of achieving the goal. So if there is a part of patient involved, you let the patient know. So we be working towards dressing, okay, upper extremity or upper body. So the role of you patient, you have to do this A, B, C, D. Or we will be learning how to brush. So the part of the patient will be doing this and this and this. So you argue with the patient after setting the goals. Then I want to come to this point that Miss Epiphany has raised. So we see that it's better when you let the client, the patient, know what you're going to do right then. But to some extent, I am asking myself, of course, it depends on the level of learning for the patient. For instance, you're going to work with a patient who is having autism, okay? The patient is falling in that spectrum. Now, if you present all these tasks to the patient, we're going to be bathing, brushing, botoning, all this. Of course, when you introduce this to the patient, it prepares the mind of the patient, and the patient sits waiting for that activity. So can't you think that this patient, to some extent, it can distract? You know, this spectrum children, under that spectrum, sometimes they lack the concept of the mind. You know, if you introduce all this, can't it distract the intervention? Thank you very much.
Thank you. So, okay, thank you, Mr. Jean-Claude. Thank you so much. We have a second question here from one of the, yes, I think I missed it, from Mr. Joseph. He asked the second, he said, how long, I'm trying to read the chat out now. He says, how long to practice for enough engrams so that the patient can keep the task even at home? I think Mr. Karim and the speaker answered this already. Okay, you may want to add one or two things to it, please. Mr. Speaker? Mr. Speaker?
Sorry, can you come up with the question again? I didn't get it.
He says, how long to practice for enough engrams so that the patient can keep the task even at home?
This seems that this person has joined very late.
Very late, right?
Yes.
I'm not even to compare.
So, but I will just keep it short.
Okay, if you feel it will take time because time is against us, yeah, we may have, the person will be receiving the slides and can always send us an email. Send us an email at OTHubspot20@gmail.com. Can one of the team members help me drop it in the chat, please? OTHubspot20@gmail.com. When you send that email, you know, a response will be given to you. All right, so Mr. Speaker, one more question, but it's going to be in two different forms, and then we'll be rounding up for tonight. If you still have further questions, you may want to drop it in the chat still. We'll see how quickly we can have every member, the panel members and the speaker to answer that. All right, so for the block and random practice, are there evidence-based recommendations or considerations as to which of the two, is best used with kids? Personally, I already have a preference. My preference is the random practice, however. But then, are there evidence-based recommendations as to which of them is best when you're working with kids? And also, what are the indications, maybe the diagnosis of in childhood psychiatry, or in children generally, physical aspect of occupational therapy, in any of the branches, what indications would determine which one we should use for, in children? So 2 questions in one.
Okay, that is subjected to debate, which I believe everyone can actually contribute in that regard. But if you go with what I presented, I made it clear that there are a lot of evidences around, but the first part of the evidence has always been around what has been done in the past. So most of the researches that we have in this century are more towards, they are climbing on that existing researches. So now there was a particular study that I mentioned, and around, I think, 19 something, I think around 1980. So that particular study was based on a child with Down syndrome. And at the end of the day, they first of all go with block presentation, and then they come back to, after the child achieves some levels of performance, they transfer the skills down to random practice for adaptation to setting. And if you look at what we have out there, what scholars are deliberating about now is that it is better when you are presenting an activity to a child or even whatever patient, once you are if your patient function at the beginner, which mostly every pediatric population falls in that. Somebody mentioned autism, Down syndrome, CP, whatever it is. Just consider them as if they have not achieved any learning skill. So they are at beginner phase. So if you go with block presentation, that gives them an ability to be versatile and be very conversant with that particular skills. So when you see some performance on task where the child makes some attempt to repeat that skill, then you know that the child, the memory trace is started forming. So you can transfer the same activity that you are engaging the patient into random sequence, so that adaptation that you want in the retrieval practice can set in. So for me, I always advise my co-practitioners or whoever, my own practice has always been around that theory. We start with block presentation. Once I see any movement from the child, that the child make an attempt to show me that I understand the next move, then I go into random consideration.
Okay, all right. Thank you so much. Any other contributions quickly? Okay. All right. So Mr. Kenya dropped the email address in the chat. Joseph, you may want to send us an email to better clarify your question and get answers to your question. Thank you so much, everyone. All right. So we have just about 10 minutes to the end of today, the end of the second edition of our webinar series, Occupational Therapy HubSpot Team. And I'm so excited that this has come to an end, frankly. It's been a wonderful learning experience. It's been a wonderful time coming together as a team to put this together. On behalf of the rest of the team, myself, and the entire team, OTHubspot team, we say we love you, we appreciate your time, believing in us, trusting us to deliver, and I think we have. We had a fantastic presentation yesterday, and yet a better fantastic one today again. So we're committed to doing this. However, for further questions, you can follow us on any of our social media platforms. We are on Instagram, just as OTHubspot. We are on Facebook as OTHubspot. We are on Twitter as OTHubspot. And you can always reach us from everywhere and everywhere, on all our social media platforms. Also, watch out for us. There is more from where this has come from. This webinar series has come from. We hope to serve you more. Now, to conclude, we have a needs assessment form that we would want every of our participants to fill. And the link to that form is on the WhatsApp group. Now, that form basically is more like our registration form. That's why nobody filled the registration form. You just join the WhatsApp group directly through, through our adverts and publicity channels. So when you join the link, the WhatsApp group, Mr. Emmanuel just copied up the WhatsApp chat group onto the chat now. If you join the group, you'll see the form on the group. Please fill out the form, write your name exactly as you want it on your certificate, and we believe that whoever fills that form wants our certificate. So yes, write your name exactly as you want it on your certificate. You will have your certificate in your email as soon as possible. I think by the end of this week, you should be getting, this new week we're coming up with, you should be getting your certificate. Thank you so much. We are off now. We're done now. You may want to unmute and say greetings to everyone. You may want to say greetings to somebody. Feel free to unmute now. We're done. Have a wonderful rest of the year. And we hope to see you next year again with maybe a new training or a new webinar series, a new seminar, whatever it is. We hope we'll see you next year. Enjoy the rest of your year and have a wonderful, wonderful week and blessed week ahead of you. God bless you all.
Thank you, OTHubspot. We are grateful. Thank you so much. Thank you, everybody. Thank you, thank you, Timbers. Thank you, everybody. It was very educating. It was informative. It was an eye-opener. We really do appreciate it. Thank you so much. God bless you all.
God bless you.
Thank you. God bless you.
Mrs. Epiphany, thank you for joining.
Thank you so much.
Mr. John Claude, thank you. Yes, Mrs. Barakat, Miss Nima, Mrs. Latifa, Ola Tunji Solomon, Mr. Samuel Kenge, Mr. Talabitayo, Moizere Alexander, thank you so much. Mamta, Namaste, Rukie, Esther, Charlotte, Denise, Sister Raymond, I see you, my neighbor.